Thank you so much. Hi, everyone. My name is Jamie Fay. I'm a pediatric hospitalist at Maine Medical Center. I work a lot in the newborn nursery, and I'm here to give you a brief overview of where we are at with hospital management of the opioid-exposed newborn. Thanks for having me. I'm really happy to be able to support this very important work that you're all doing. Next slide, Liz. I have no relevant financial disclosures. You can go to the next slide. And these are my objectives. I'm just going to talk a little bit about the historical background of how we used to manage neonatal opioid withdrawal syndrome in the hospital to provide a little bit of context for the why of implementation of Eat, Sleep, Console. And then I'll talk a little bit about what Eat, Sleep, Console looks like and what the benefits of it have been at our hospital. Next slide, please. This is just a table outlining the symptoms of neonatal opioid withdrawal syndrome. I assume that everyone on this call has a decent idea of what those are, so I'm not going to get into a ton of detail about them. Next slide, Liz, if you don't mind. And then I would like to talk a little bit about the Finnegan scoring system, which is here. And the reason is that this was the center of the paradigm for treatment of opioid-exposed newborns for a long time, including when I started residency, which somehow is now over a decade ago. And the treatment protocols varied with institution and geography regarding specific thresholds and types of medications used, but the fundamental concepts were the same. We used the Finnegan and took a baby that was exposed to opioid medications or opiates in utero, and every 4 hours they were scored by a bedside nurse using this tool. Scoring involved separating them from their parents, unswaddling them, turning all the lights on, and then all of the things listed here were assessed. So if the baby scored more than 8 3 times in a row, more than 12 once in a row, or more than 16 once, then you started pharmacologic treatment, which typically involved transfer to the NICU, putting them on a monitor, and starting some form of opioid medication, which most commonly was neonatal morphine solution, but sometimes it would be methadone, and historically diluted tincture of opium had been used, although I'd never seen that before. And then when using morphine, which again was the most common, we administered the medication every 3 hours and continued scoring, escalating the dose of morphine until the infant was quote unquote captured, meaning that their scores were acceptably low or they had maxed out on their dose, at which point you added an adjunct medication, typically either phenobarbital or clonidine. And once the infant was captured, we would initiate a wean, and the wean typically would be daily, and it was 10% of the maximum dose per day until the dose was sufficiently low that we could just discontinue it. We would discontinue it, monitor the baby for an additional 24 to 48 hours, and then the baby would be theoretically ready for discharge. Next slide, please. So this approach had its shortcomings, and I'm going to go through them quickly now. One of the first ones that I want to get into is that there are questions regarding the safety of the medications that we use to treat withdrawal and their long-term effects. There's a growing body of evidence suggesting that there is long-term harm primarily from a neurodevelopmental perspective associated with neonatal opioid therapy. There are obviously a lot of complicating factors in this research that are difficult to control for, like environment, other substance exposure, maternal nutrition status, socioeconomic factors. But this is just to suggest that just to show that there's evidence to suggest potential harm, although it's not necessarily cut and dry. Next slide, please. And then I just wanted to come back quickly to the Finnegan and point out a few of the elements on the scale, whose relevance in determining whether one of these medications should be administered to a newly born baby in light of the potential consequences of giving the medication could be considered objectionable. So a lot of these are obviously signs of withdrawal, and it's helpful to look at them globally as such, and some of the things like I've starred here, but exaggerated moro, increased tremors, or exaggerated tone are obviously signs of a hypermetabolic state and raise concern for the possibility of things like weight loss. Excoriation is potentially uncomfortable and can lead to infectious conditions, but I'm not sure that it should prompt us to give a baby morphine. We don't necessarily give someone morphine under other circumstances for excoriation. And then things like respiratory rate and body temperature obviously deserve assiduous attention, but again, I'm not sure that they warrant morphine exposure, and certainly not wanting to administer medications that may have long-term detrimental neurocognitive impacts because of things like sweating, yawning, mottling, nasal stuffiness, sneezing, nasal flaring, or getting too much enjoyment out of a pacifier. So again, these are all very important and helpful to recognize as signs of withdrawal and can be used to guide us in determining whether or not a baby's other significant symptoms are due to withdrawal or not, but no one was really convinced that the presence or absence of nasal stuffiness should be the deciding factor in whether or not a baby gets morphine. Beyond these concerns and the fact that the Finnegan is not a function-based scale, it's never been validated. It doesn't have excellent inter-rater reliability. A lot of the items are somewhat subjective. And then also Finnegan herself, who the creator of the scale, actually never intended for it to guide clinical management. So it's kind of interesting that for a long time, it was the thing that guided clinical management of these babies. Next slide, please. So we've talked about the pitfalls of the Finnegan and the potential risks of medications used to treat withdrawal in babies. And now I just want to talk a little bit about the traditional treatment paradigm and its effect on families. This was a wonderful study that was done at Dartmouth in 2016. It illustrates this really well. There have been other subsequent studies done, including in our own hospital. They all have similar, they all come to fairly similar conclusions, but basically it's a study where they interviewed families and identified 5 domains of family experience of their time in the hospital with their baby with opioid withdrawal, including a desire for more education, parents valuing and wanting others to see the value of their role in the care team, impact of staff interactions and communication, stress imposed by transfers between units and inconsistencies among providers, and other external factors such as the logistics of caring for other children at home and difficulty that they experience getting into medication-assisted treatment programs. They identified quite a few modifiable factors that had a negative impact on the experience. Next slide, please. Another issue was the length of hospitalization. It was long and getting longer, and these prolonged hospitalizations can have significant implications in terms of strain on families and interference with infant bonding. Next slide, please. Use of resources was another issue. It's most of these babies were treated in the NICU, and as you can see here, that was extremely expensive. Next slide, please. So there were lots of issues, and in the past 5 to 10 years, things have really changed, and it's been a cool thing for me to see over the course of my early into mid-career, because the way that we take care of these babies during the birth hospitalization has completely changed since I started my residency in 2011. This paper came out in 2017, and it was sort of the impetus for all of this. It's from the hospital medicine and neonatology groups at Yale, and it was a huge quality improvement project that they did to improve the care of infants with NOWs, in their institution. They were interested in the fact that the AAP guidelines for the treatment of NOWs state that the first line treatment of withdrawal is non-pharmacologic measures and that medications are second line. And they noted that non-pharmacologic measures are really difficult to administer in many NICU settings, because although there is a move to provide private rooms for NICU patients, a lot of NICUs are still big, open, bright rooms with many babies in the room, alarms, people talking, coming in and out, emergencies happening, and none of that's conducive to creating the quiet, low light, low stimulation environment that many of these infants need. And it's also not conducive to parents rooming in and providing other non-pharmacologic measures to support babies through withdrawal, such as skin to skin and breastfeeding. Matt Grossman, the first author on the paper, in a webinar that I listened to, made a really great comparison that I use a lot, which is saying that treating these babies in the NICU would be the same thing as treating patients with asthma in a setting where you couldn't give albuterol. So anyways, the Yale group thought really hard about how much the treatment of NAS truly needed to take place in the NICU and why it traditionally had. And then they moved the care of newly born infants with NAS or NOWs out of the NICU and onto the general pediatrics floor. And they worked really hard to empower the families of these infants to room in and provide care for these babies. They did a lot of staff education regarding the importance of non-pharmacologic care. They worked very hard with their lactation team to encourage breastfeeding in the absence of contraindications. And they also developed a new withdrawal scoring tool called the Eat, Sleep, Console tool, which was a simplified function-based assessment, which instead of focusing on some of the more academic signs of withdrawal, such as sneezing, exaggerated moro, focused on whether or not the baby can do what I describe to people as its baby jobs, which are limited and include feeding, sleeping for at least a little while, and not screaming too much, not being too challenging to console. They also questioned the dogma of Q3-hour standing doses of morphine when it was used and Q24-hour weans, and they went forward with altering their dosing regimens and implemented PRN morphine dosing when appropriate, as well as rapid morphine weans. Next slide, please. These are just some run charts that are, I realize now, really hard to see, I'm sorry. But it shows the effect of their QI project. They reduced the mean length of stay and cost of hospitalization, and they decreased the number of babies who are treated with morphine. In their institution before implementation of this project, 96% of babies were treated with morphine, which we had a much lower baseline than that, but they reduced that from 96% to 28% over the course of their project. I think one thing that this whole experience showed is that there's a lot of inter-institution variability. All of the babies went to the NICU and at Yale no matter what, and a huge percentage of them did receive morphine. They also, next slide please. They also increased percent of breast milk fed infants and decreased the number of NICU transfers. Next slide. In 2018, we decided to undertake a similar project. We had the goal of improving care of infants and families affected by NOWS. It was a multidisciplinary clinical transformation project. It was oriented towards the unique needs of our institution and NOWS population. Our primary aim was to decrease the percentage of pharmacologically treated substance-exposed newborns by 20% via implementation of the Eat, Sleep, Console care tool. We did this via multiple PDSA cycles, many of which emphasized staff education. Next slide, please. So just a little bit about the Eat, Sleep, Console care tool. It was developed in collaboration between faculty at several institutions. It evaluates several behaviors key to the function of an infant. We still assess for signs of withdrawal, tremors, fevers, etc. However, the need for treatment is based on the functioning of the infant related to eating, sleeping, and consoling, always while maximizing non-pharmacological treatment before introducing medications. This helps to enhance partnership with families by placing them at the front and center of the baby's treatment and helping to avoid morphine treatment for what can reasonably be viewed as less relevant symptoms. Importantly, it also allows for less laborious documentation on the part of nursing staff. Next slide, please. This is what the tool looks like. Each time the infant is assessed, they're no longer removed from whatever hopefully comfortable situation they find themselves in, mom's arms, etc., in order to avoid artificially increasing their withdrawal behaviors. Instead, they're assessed after feedings, ideally while skin to skin or being held or while swaddled. The nurse will review the newborn care diary that the parents are asked to keep and discusses Eat, Sleep, Console behaviors since his or her last assessment with the infant's parents. If the infant is able to eat adequately, sleep well, and is consolable without significant sustained effort, the parent and nurse agree to continue current management. If not, there is a review of the non-pharmacologic care interventions that can be optimized, and this is attempted only when the infant is consistently unable to eat, sleep, or be consoled in spite of optimization of non-pharmacologic interventions is pharmacologic treatment considered. Next slide, please. This is just a list of non-pharmacologic interventions that we use, which of course are interventions that can be used to soothe any fussy baby. Next slide, please. And then I just want to talk a little bit about what we expect these little ones to be able to do, because I think there's some nuance to it. We expect adequate oral tolerance in light of the infant's gestational age and postnatal age, and with consideration of other comorbidities. So I think this is an important point that comes up a lot. If they're sleepy because they were born a few hours ago, or they're late preterm, or they have a cleft palate, or there's some mechanical issues with latch and suck related to, mom's nipple shape or a tongue tie or whatever, but the baby's sucking well in a pacifier, that doesn't count as poor eating due to NAS. And we have more and more frequently been finding that we have a lot of benefit from getting speech and language pathology involved with these babies to provide their input on what the challenges with feeding are related to. Poor eating due to NAS tends to be more a baby that's frantic and uncoordinated and fussy, or has increased tone and tremors that interferes with their ability to take a bottle or latch, or if they're too tachypnic from withdrawal to be fed. It's important to remember that there are other reasons why infants may struggle to feed, and that's why looking at the big picture and keeping in mind the other signs of withdrawal evaluated by the Finnegan can be helpful in sorting out why a baby may be struggling to nurse or take a bottle that might not be related to their prenatal opioid exposure. It might require a different intervention. Next slide, please. The sleeping portion questions whether the infant can sleep for more than an hour after a feed, or if they can't, if it's due to their opioid exposure prenatally. It's important to keep in mind that polysubstance use can complicate this question. Sometimes in the first day of life, infants are awake and fussy due to nicotine or SSRI. withdrawal. And of course, cluster feeding and sleep interruption due to being in the hospital don't count as interrupted sleep due to NOWs. Next slide, please. So the consoling question, is the baby unable to be consoled? We say that 10 minutes is a reasonable amount of time to console these babies. Again, it's important to rule out other issues beyond NA NOWs, and the tool also requires that we assess the degree of consoling support that babies are requiring. Next slide, please. This is our PRN morphine guideline. I'm running out of time to discuss it. I'm happy to answer any questions about it in the future. I think the bottom line is that this guideline has really reduced the number of doses of morphine that babies receive in the hospital, even when they do end up requiring morphine. I think that's one of the more meaningful changes that we've seen. Next slide, please. This project also involved a lot of staff and family education, including implementation of prenatal consults in our OB clinic that have been generally well received. Next slide, please. Oh, one more slide. This is just an example of some prenatal education materials that we provide during our consults. And then I just wanted to go through sort of what we've seen in terms of the benefits of this project at MaineMed. My colleague, Dr. Alan Piccirillo, who led the project and managed the associated data, shared the upcoming slides with me. Next slide, please. So we reduced our rate of pharmacologic treatment from 35% to about 8%, and perhaps even more significantly, next slide, please. We effectively lowered the total average doses of morphine per patient by about 80%. Next slide. Our overall length of stay was reduced. Next slide. And as you can see here, the length of stay for infants who are not treated pharmacologically has been unchanged, which makes sense because we still keep them for 5 to 7 days for monitoring. Next slide. This slide just illustrates cost savings to our institution, which have been significant. And this slide just shows that we haven't had an increase in readmission or ER encounters within 30 days of discharge since implementation. And I think that's an important question that, is maybe still unanswered, is what are the long-term consequences of the Eat, Sleep, Console model versus the Finnegan model. But at least initially, we haven't seen any major discrepancies. Next slide, please. Unfortunately, we've yet to complete a formal study of the families of babies with NOWs evaluating the impact of our new protocol on their experience in the hospital. We're actually working on something right now, but it's going to take some time. The anecdotal feedback has been very positive. These are just some quotes from a mom who had experienced hospitalization prior to Eat, Sleep, Console implementation, and then another after we had implemented the new care approach, and she reported a very positive experience, particularly in comparison with the Finnegan. And then these are just this next slide, sorry. These are just some future directions that research in QI could potentially take, including evaluating long-term developmental outcomes for children who are treated pharmacologically and those who aren't. And then I think there will probably also be some value in evaluating the family perceptions of the two approaches, and just ways that I think we're better, but we still have a long way to go, in ways that we could be supporting these families during their hospitalizations, which tend to be significant stressors, sort of by both in terms of financial and psychological and physical stress. So we're working on it, but we're not perfect for sure. And I think that's the last slide, right? That's it. I'm happy to talk to answer any questions.
Thank you so much.